Hi, my name is Manish Shah. I am a pediatric epilepsy surgeon at Children's Memorial Hermann Hospital in Houston, Texas. Thank you for joining me today, and thank you for coming to UTHealth Neurosciences Epilepsy Awareness Day presentations. I'm going to be talking about different types of epilepsy surgery. I have no financial disclosures. So first of all, just for those who don't know, Houston is here in Texas, and this is our wonderful children's hospital, Children's Memorial Hermann. So just a phenomenal place to work and take care of patients, and I think we do really good work here. So I'm very proud to be here. It's a little bit about me, where I trained. I did some special training in pediatric neurosurgery and pediatric epilepsy at St. Louis Children's Hospital after residency there. And I have been on faculty since 2014 here. It's a little bit of an overview of the different types of epilepsy surgery. So think about epilepsy surgery as tools in a toolbox. So why do we do it? We'll talk a little bit about all the tools that we have in our toolbox, and how do you do a big project? Use the right tools for the job. So we're not going to use some tiny little hammer to drive in a big nail, or vice versa. And we have to judiciously choose what surgery we're going to use for what patient to have the optimal outcome. So what is the role of epilepsy surgery? There are going to be a lot of great talks today that talk about, is the patient a good candidate for resection? How are we going to figure out where the epilepsy is coming from? And what are the goals of the resection? So it isn't, in pediatrics, it's not just seizure freedom or reduction in seizure burden, but it's actually to hopefully disrupt that developmental regression they're having and improve that to drastically improve the quality of their life currently and then also in the future. So we can have happy older children and adults and make them as happy and productive as possible, hopefully have families with them, this kind of thing. So it's a disorder of brain networks. That's that paper we published 10 years ago. And when we do epilepsy surgery correctly, we can really restore what looks to be an awful EEG rhythm to something that looks a lot more normal. This is a child who we did callosotomy on, who's having that developmental arrest. So it's one of the first pieces of data that shows that networks in the brain can become more ordered after we correctly treat epilepsy. Here was epilepsy surgery, and that's a very important thing to think about. That's another diagram from that paper. So what are these different types of epilepsy surgery? So we'll just start from the smallest of vagal nerve stimulation to start to take out parts of the brain, temporal lobectomy, which is what it sounds like. We take out the temporal lobe or parts of the temporal lobe, specifically the mesial structures like the amygdala and hippocampus. And then we can also take out the front part of it called the anterior temporal lobe, versus disconnective procedures like the Corpus Callosotomy, where we can divide the big fiber bundles that connect both halves of the brain. And then we can progress on to something that does both a little bit of removal and also disconnection, the quadrantic disconnection, and then get to hemispherotomy or functional hemispherectomy, depending on who you talk to, where we are disconnecting and partially taking out one half of the brain. So then how do we get to one of those? We do invasive monitoring with either subdermal grid electrodes or robot-guided or frame-guided stereotactic electroencephalography, SEEG. And those two bits of invasive monitoring can help us really hone in on a target for surgery, to then be able to do what's called a focal resection, or take out a very small part of the brain, either through open surgery or through laser ablation, or if we can't do laser ablation, potentially stimulate that part of the brain, because maybe potentially it's eloquent or deep, and see if the stimulation can help reduce the seizure burden. So moving on to vagal nerve stimulation, patients with multiple regions of onset for their epilepsy. So this is like a diffuse generalized epilepsy. It's coming from both parts of the brain. Often they're genetic epilepsy syndromes, The benefits of this is that it's a very short outpatient procedure. It's completely reversible. We can turn it off. And the vagus nerve, to cite my colleague, Professor Tannen, who's going to talk, it's like the chill nerve for the brain. So we don't know exactly how it works. We know it has at least a pathway that connects it into a certain part of the brain called the NTS. But it's interesting in that prolonged stimulation of the vagus nerve can not only reduce the seizure burden and seizure frequency in patients, especially over time. So the more you modulate, the more you stimulate this nerve, the better it works. So even if it's only 50% effective initially, it can really get up to 70% or greater in terms of its efficacy after 5 years. So you can imagine prolonged stimulation of this chill nerve chills the brain down. But interestingly, it also works in conditions like depression and rheumatoid arthritis. And so we really don't know fully how it works. We just know that it cools the brain down. The risk, of course, that doesn't always work. There's some minimal risk of infection, either in the initial implantation, which is very low, or during the every 4 to 5 year battery exchange that needs to be done. Sometimes you can have voice changes, but usually the settings can be modulated. Overall, low risk procedure. It's almost, you can think about it like another medication with very few side effects. So it probably isn't going to cure the epilepsy, but it's going to help a lot over the long term. It's like the generator / battery pack is put in underneath the clavicle on the left side in a variety of different incisions, and then it's connected to an electrode that is wrapped carefully around the vagus nerve, which lives between the carotid artery and the jugular vein. So then moving on to corpus callosotomy, patients with drop attacks are really, we're trained in as neurosurgery residents and then attending neurosurgeons. When we hear the term drop, we think of corpus callosotomy because it's really 90 to 95% effective when done in a complete style to eliminate these atonic seizures or complete loss of tone. But then it's also very good for epileptic encephalopathy, in a child in which the seizures are so profound and happening all the time that they're causing developmental regression. When that epilepsy is diffuse and turns into what's called encephalopathy, it's very great for that. That was the case I showed earlier, where the brain network were that resting state brain function and the network architecture was restored after surgery. So for this kind of patients typically spend a couple of days in the hospital. I cite 60–70% effective at stopping drop attacks for all patients of all ages. For children, though, it can really be 90–95% is more accurate number. The risks are, the older you get, the harder it is for you to tolerate coordinating between the two hemispheres. So doing what's called bimanual tasks, things together, where the hands work together. And then if you section the back third of the corpus callosum and you're older or an adult, there's a risk that you can have trouble with very complex visuospatial tasks, like closing your eyes, tracing a number on the hand. And then finally, from the actual surgery itself, there are a variety of ways to do this. We tend to do this with a small craniotomy here, which is a small window a bone that we take off, and we look in between the two hemispheres directly with a microscope. Other centers do this with lasers, and other centers do this with an endoscope. But at the end of the day, the procedure is pretty similar among all those. The operative time is probably a little bit shorter for an open corpus callosotomy versus the other two procedures. And if there's any bleeding, it is much, much, much easier to stop in an open approach. So there can be some transient weakness because the area through which we approach the callosum is the supplementary motor area, but this tends to be extremely transient, especially in younger patients. So a lot of different ways to do this. Great surgery. So this is the craniotomy way. And this is where we take the small window bone off. We find at the top of the callosum. We come down to the midline, and then we either start by going forwards or going backwards. And then at the end, we can be sure that we've gone from all the way to the front here to all the way to the back. And this is just a cool 3D picture of what that corpus callosum looks like in terms of tract. So the other benefit of doing callosum is sometimes it may appear that the epilepsy is generalized, but in reality, it's actually coming from one side and very rapidly generalizing. And so that's what's called lateralization. And then afterwards, we can potentially do focal resection. And we found this to be very helpful in sometimes what's called catastrophic generalized epilepsy, where the child is just seizing continuously or the patient is seizing continuously. And then afterwards, you can find one spot, one focus, and then have a much higher likelihood of having a cure versus specific genetic conditions like tuberous sclerosis, where there are a lot of different culprits that could be causing problems. After the callosum is done, lateralization is possible, and then we can figure out which culprit is the correct tuber culprit. So then moving on to a bigger kind of disconnection. So here we're going to disconnect 1/4 of the brain. So this is called parieto occipital temporal disconnection, or if we're going to spare the temporal lobe, parieto occipital disconnection. And here we are looking to disconnect the parietal lobe and the occipital lobe, which is actually pretty small. So this is the visual cortex. This does a lot of higher order sensory processing. And we specifically are going behind, as best as possible, what is the primary somatosensory cortex, which is the part of the brain that is going to be directly first order processing the sensory signals coming up from the limbs. So we go behind the postcentral gyrus, go down to the falx here, go through the ventricle. We often leave in a ventricular drain and drain for a few days, about 5-6 days after surgery, to help reduce the risk of hydrocephalus, which is an expansion of the ventricles, which is one of the possible complications, the need for a shunt after the surgery. This is a really great procedure when done on the right patient. So here's a 19-month-old child who has a posterior quadrant here on the left that was just continuously seizing. And here we go. This is a picture of the magnetoencephalography dipoles, and there'll be another set of talks on this during this that you'll learn a lot more about this. But anyway, this helps us localize the left posterior quadrant, and this child has been seizure-free for, I think, about 5 years now. So a very great surgery when done on the correct patient. So then moving on from quadrantic disconnection, we can do hemispheric disconnection. So we used to actually do an anatomic hemispherectomy, which is taking out the entire hemisphere. And it was actually first done for a terrible type of brain tumor called a glioblastoma. And that was done in the 1920s, so almost 100 years ago. And unfortunately, we found from that series, Walter Gandy, that the tumor would come back to the other hemisphere. So then in the 50s, it was taken back up, 1950s, it was taken back up for hemispheric, well, 1/2 of the brain onset epilepsy. And we found over the years that for it to be an incredibly useful tool in the arsenal, specifically for hemispheric onset epilepsy. So for patients who already have weakness on the other side, so they have something called a helper hand, where they're not really moving their fingers, or their hand is already not moving very well, again, because of the constant seizures coming from 1/2 of the brain, and then specific pathologies such as perinatal stroke. Children can do very, very, very well, and adult patients can do very, very well from this. Spend about a week in the hospital after surgery for us draining the fluid. And for all comers, there's about a 70% seizure freedom rate after surgery, with very careful selection of certain pathologies, so we can get 90-95% seizure freedom rate. So there is a transient risk of having increased weakness on the other side of the body, but usually, again, we're looking at patients who are already weak in their arm and hand, And so they end up not having a really long-term detriment from this. And often when they stop seizing as much, they're a lot more mobile with the remaining function they have. And then anatomically, you're going to get a vision loss from one half of the opposite side of the visual field. But often the patients are seizing so much from their hemispheric onset epilepsy, this has already happened. So this is the procedure itself. So we take a window around, this is called a peri-insular hemispherotomy. So we're going to take a window around the insula, which is this structure here, and basically go around it. And so we start by doing a wide resection of the operculum and then doing an occipital-basal disconnection, an amygdala epicampectomy, which is part of that mesial temporal lobe over here, that if we were doing a temporal lobectomy, we would take all this out. So here's that part. Then we go through the ventricle and do a transventricular corpus callosotomy. So you can see what happens. That's the corpus callosum there, and we cut in the front and the back. Then we do frontal basal disconnection, that's up here. And then an insular resection, usually take 1 or 2 millimeters off the insula here. And we leave a ventricular drain. And the outcomes can be really spectacular. There are so many variations on this technique, but in general, they all do a similar thing, whether they're done open, or they're done with an endoscope, or they're done with an exoscope. They're all really quite similar. And it's one of the more challenging procedures in epilepsy surgery, primarily because it's actually very hard to do some of these basal disconnections. And not a lot of centers do this in the youngest children. So here we were fortunate to have a really wonderful team. This is a child I operated on about 5 to 6 years ago, who was having 100 seizures a day. They're all coming from his right hemisphere. And we did a 6-hour surgery. He spent 7 days in the hospital, and he's been seizure-free since then. And it's again a picture of the MEG, very, very helpful in helping us localize, along with the 2 focal cortical dysplasias that he had on that side. And this is, there's one here, there's one here. This is after surgery. And his long-term follow-up has just been spectacular. He's been doing really, really well. So again, you got to use the right tool from the toolbox, and you can have some really great outcomes. So then moving on to something much smaller, focal resection. Seizure freedom can be anywhere from 50-50 or less, depending on the pathology, all the way up to 90%. And so this is really the heart of all the investigations we do. Can we resect as little brain as possible to get a really good outcome? That's what we do. And we have a lot of tools to try and help us do that. And there's going to be a lot of talks today about that you can go over. So when do we do invasive monitoring to help us with focal resection? When we have more than one hypothesis for focal resection that are far apart. So if they're close together, there's no point doing invasive monitoring. We just do a 1-stage surgery where we do monitoring in the operating room and then figure out what tissue we need to take out and take it out. But when we need to do mapping for speech and motor function, there are 2 options available to us: subdural grids and SEG. So subdural grids, the quote-unquote old way, there are actually a lot of different old ways to do this, but this is the recent old ways. There are epidural grids, and there are all kinds of ways you can imagine to try and extract electrical signal from the brain. But this was a relatively safe way to map the surface of the brain. Unfortunately, 2/3 of the brain cortex is buried. And so what inevitably happens is that we often have to put in depth electrodes, and those depth electrodes can be pretty big. And this is a big surgery, subdural grids. And it comes with its own host of complications, anywhere from 10 to 20% of getting hemorrhages and infections. And so a lot of the field has really moved on to using robots. We have been one of the pioneering sites in using this small Medtronic robot that's bed mounted, but we have a giant robot called Rosa. There are just an unlimited number of ways to do this now. You can not even have a robot, you can use a frame But the goal is to put in tiny electrodes to be able to map and monitor multiple parts of the brain that you are considering hypotheses for focal resection. And so here's a quick case of a child who has a lot of different tubers. And so we put in a bunch of electrodes. Interestingly, this is the tuber that was calcified. Some people really say that calcified tubers are the ones causing the epilepsy. You should always choose after them. It turned out that wasn't true. And it was actually the tuber that was up here, not back here. And was very, very helpful. This child had a dramatic reduction in her seizure frequency years later. So moving on then to stereotactic laser ablation. There are multiple vendors, but the point is that we can do this in real time in the MRI, watching what tissue we're ablating, whether you use the Monteris or the Medtronic visual aids. We toast the tissue. We get it up to as close to 90 degrees Celsius, which is when we know the tissue is being destroyed for a few minutes. We can make almost a 2 centimeter sausage-like lesion, so that it's usually about 17, 18 millimeters. And you can place multiple bolts. You can do complicated things, but the way you should really think about visual aids, at least laser ablation, is if whatever your favorite city park is probably not square, and it probably has a bunch of fountains in it, stuff like this. So imagine if you had a blind lawnmower who could only mow a straight line backwards. And so whatever direction you're going to send this lawnmower in, and then pull the lawnmower backwards to mow that single strip, that's what a laser ablation is. So if you can get it, whatever part of the park you want to mow in that specific spot, it's going to work. But otherwise, there's this very complex set of trajectories that you have to do, and then you're not really ablating after at that point. You're really hoping that disconnection can do it. So just because we hear this term laser doesn't mean that it's the right tool for the job. Sometimes open surgery is the right tool for the job, and it's really a center that can do it all that's going to offer you the right tool. So optimal targets are small things for laser ablations, things like heterotopias, hypothalamic hamartomas, and then in the adults, it's just a home run indication. The mesial temporal sclerosis has really reduced the number of adult temporal lobectomies. And then deep-seated lesions that it would be much more challenging to take out with open surgery. And then again, thinking about that per fiber trajectory, about a 2 centimeter sausage you're going to make in the brain. So here's a case of MTS we did in an 18-year-old. And she is seizure-free many, many years later with this careful sausage we've made. And then this is one of the hypothalamic hamartomas we've done. This child actually was very weak on his right side for many years. And after we did this, he's been seizure-free for about 3 years now. And he's actually completely regained his strength and has been running around quite well. And so treating the seizures really, really can drastically ameliorate development. So for thinking about this SEG and also stereotactic laser ablation, you really need to be at a center with epileptologists who can understand, you saw that picture of all the electrodes in different spots. They're not all just linear, they go in different spots. How do you interpret that data? So you have these tiny, tiny little fishing lines. How do you interpret where all the fish are or where the big fish is using the data you're collecting from all these things? And we really need really great epileptologists who understand in three-dimensional space how that seizure is propagating. And then for laser ablations, you need to think about the trajectories. Think about that blind lawnmower. So then the final part of the talk, responsive neurostimulation. So in the initial approval was for 2 electrodes being placed in both of the hippocampi. You can't take both hippocampi out. And if you have bilateral temporal lobe epilepsy and it's coming from both these things, this is a great device for that. Over time, we are learning how to use this best as it's off-label for pediatric usage. Really, great tool in the armament for certain patients who have non-resectable epilepsy And we're learning how to modulate more and resect less with this. And that's the talk of a whole bunch of speakers from the session. One thing is, I will say, is you need almost a centimeter of skull to implant this battery pack. So you can't really put it in a very thin skull or a very small child. And this is what it looks like when we have it in. This patient has had some reduction in seizures post-operatively, and overall that's a good outcome for her. So finally, there's going to be a lot of talks about this, but Medtronic has gotten approval in the last few years for thalamic deep brain stimulation, and the Professor Patti and Professor Latu are experts in this, and we have more talks on this along with Dr. Tandon. And so here we really need to make sure we have an anterior nucleus of the thalamus. So we do very special MRIs to make sure that we can see this thing before we try and really do an orthogonal, perfect perpendicular stimulation of this. And so even being a millimeter off is not good. There's some recent data that was published in the last few months about this by Professor Gross and company. And so this really is high-tech stuff that needs a very, very, very high level of precision to be done correctly. And it's got to be done in the right patient, and we're working out that kind of patient selection. So epilepsy surgery, lots of different types, a lot of tools in the toolbox. And I think the most important thing is you need a multidisciplinary approach. You can't go to a place where, hey, look, all I do is vagal nerve stimulators, or all I'm going to do is blow that thing up with like 5 laser trajectories. You really want a very, very careful approach to what you're being offered, so you can have optimal outcomes. So thanks again for joining, and I hope you have a very educational day with us in Epilepsy Awareness Day at Children from Herman, UTHealth Neurosciences. Thank you.